1 or 2 hours before their shift. Caffeine with moderation, avoiding light. But the most important thing, from a practical point of view, is making sure they get enough sleep if they're sleeping. Because most people, so the problem that I see is that they tend to burn the candle on both ends. And if they have other underlying problems like sleep apnea and narcolepsy, because people can have more than one thing, make sure we treat those. Regarding those who suffer from insomnia symptoms that are predominantly associated to shift work, people who might not be very sleepy, but then really struggle sleeping when they work shifts, it is helpful to give them a short-acting hypnotic. And rather than Sonata, which is Zaloplan, I probably would prefer Zolpidem, which is Ambien, because it's a little bit longer acting. Sonata, again, has a half-life of about 1 to 2 hours. So it usually will help you fall asleep initially, but won't linger there too long. Also, you must be careful with the elderly and with women who tend to metabolize these medications at a slower rate. Tylenol PM, again, it's again, pretty much just diphenhydramine is the active component of that. Problem with diphenhydramine, it's a little bit of a dirty drug because it's not a pure H1 blocker, it's not a pure antihistaminic. A lot of the side effects, like the dryness of the mouth, are associated to its cholinergic effects. And it can stay in the system for about 12 or for about like 10 hours. So it's not uncommon for people to wake up with a hangover-like effect. So not always the best. Energy drinks, again, these either have caffeine of some sort or guarana, which is a caffeine-like product. And, there's plenty of studies, especially that come from the military, that show the almost equivalence between caffeine and modafinil. So approximately, this is the study done at Walter Reed Hospital, 200 milligrams of modafinil is equivalent to 600 milligrams of caffeine. And obviously the problem with caffeine, though, is it has a half-life that's not very predictable, because it can be as short as 2 hours, can be as long as 12 hours, depending on how quickly you metabolize it, because it's a methylxanthine related to theophylline. So tricky. Then I see here a second question here, a third question from Dawn. As these devices improve, do you have an opinion on whether there will be a shift towards using a diagnostic tools as much as home sleep apnea tests are now used? I think it is possible, because again, it's a matter of time, I think, based on the changes and improvements that I see in this technology, as our costs are incredibly high, and there's a lot of disruption happening in all of healthcare, including sleep. And it's all the tech companies that are getting involved in that. You've seen, I said, what Amazon has sent to the malls, and now you have the likes of again, Amazon, Apple, Google, even Walmart getting into healthcare. So I'm sure, again, there'll be change. I can't say how soon or how much, but I think it's very important that we adapt in a way that's proactive to make sure we continue offering quality care and costs that are not outrageous. We say, and no energy drinks. Please ask questions. Okay. Okay, so I think that those are all the questions we got for now. Maybe we can go with our next presentation, Marla, on sleep and technology.
Absolutely. And so Dr. Alex Villarreal up next, talking about telemedicine and digital sleep medicine. If at 3 o'clock in room 2, we have Dr. Maggie Graham speaking on pediatric tongue ties. So if you prefer to join that talk, you can jump in that room 2 at 2 o'clock. Otherwise, we'll go ahead with telemedicine and Dr. Villarreal.
And once again, to the audience, as Marla helps us find the presentation, my apologies. I said I was recovering from an upper respiratory infection, and my voice wasn't at my best. So sorry if the audio isn't excellent. Hello, and welcome to the Wisconsin Sleep Society Virtual Fall Conference 2021. I am Dr. Alexander Villarreal, Chair of the Department of Sleep Medicine at Gunderson Health System in La Crosse, Wisconsin. As part of my work, I have the pleasure to work closely helping develop sleep programs of several critical access hospitals and rural hospitals in Wisconsin, Iowa, and Minnesota. I'm also helping with the digital transformation of my health system, especially in my department. For those attending the semi-live portion of the conference, there is a chat function where you will be able to type in your questions. Also, I would like to take the opportunity to thank the Wisconsin Sleep Society and the American Academy of Sleep Medicine for making this conference possible. I have no conflicts of interest to disclose. We are providing medical education credits thanks to the collaboration with the American Academy of Sleep Medicine. At the end of this talk, I would expect you to describe obstacles preventing the implementation of telemedicine, to describe two different models of patient care using telemedicine, and to identify 3 technological tools used to enhance patient care in obstructive sleep apnea. Let's start by answering the big questions to have a better understanding of our situation. What? Digital medicine. So it is a field concerned with the use of technologies as tools for measurement and intervention in the service of human health. Digital medicine products are driven by high-quality hardware and software that support the practice of medicine broadly, including treatment, recovery, disease prevention, and health promotion for individuals and across populations. So pretty much, it is the technologies and the tools, the hardware, and the software used to practice healthcare. Telehealth is the use of electronic information and telecommunication technologies to support long-distance clinical healthcare, patient and professional health-related education, public health, health administration. Also, these technologies include video conferencing, the internet, store and forward imaging, streaming media, terrestrial and wireless communications. Telehealth is broader than telemedicine. Telemedicine refers specifically to remote clinical services, whereas telehealth also provides remote clinical and non-clinical services such as provider training, administration meetings, and continued medical education. The key models of telemedicine services are virtual visits, which are synchronous, patch-based interactions, remote patient monitoring, and technology-enabled modalities. Virtual visits can be domiciliary when the patient is at home, their work, or any place outside of the healthcare clinic. Additionally, virtual visits can be clinic-based when the patient is located at another healthcare clinic and assisted by a nurse or medical assistant who is typically equipped with a cart. Other modalities include phone and real-time chatting. Chat-based interactions. These are asynchronous online or mobile app communications. Now they transmit patients' personal data, vital signs, or other physiologic data to a healthcare provider, who then reviews and delivers a consultation, diagnosis, or treatment plan. Examples include secure emails or the patient portals in which you might interact messaging. Then we have remote patient monitoring, and this includes the collection, transmission, and evaluation and communication of healthcare data. This goes from a patient to their healthcare provider or an extended healthcare team. And this typically occurs outside of the office or the hospital and includes personal health technologies, such as wireless devices, wearable sensors, implanted health monitors, and more. A good example of this are the modem-enabled CPAP machines or Wi-Fi connected disposable home sleep apnea testing units. Remote patient monitoring. They support monitoring of chronic disease management, synchronous or asynchronous, and it includes the application of several emerging technologies, which include artificial intelligence and machine learning. Examples are programs used to score sleep studies using artificial intelligence and machine learning, or mobile apps available in smartphones that can help treat insomnia. And then you have technology-enabled modalities such as telehealth and the virtual care to solutions, physician-to-physician consultations, patient education, data transmission, data interpretation, digital diagnostics, and digital therapeutics. The COVID-19 pandemic was a watershed moment for telehealth and telemedicine. It has allowed us all to expand these services and harness technology to better care for patients. As you can see, the government removed several restrictions limiting the implementation of telemedicine and telehealth during the COVID-19 crisis last year. Telehealth exploded in 2 months between February and April of 2020 and has now plateaued at volumes that are almost 40 times what they were prior to 2020. However, you can still see a significant disparity in the adoption of telehealth between urban and rural areas. Rural populations have implemented only 2/3 of the level of their counterparts. As expected, some specialties are much more conducive to the implementation of telemedicine. There you can compare psychiatry versus surgery, hence greater adoption for some specialties. Sleep medicine is positioned very well for the implementation of telemedicine. Despite all the growth in telehealth, there is still significant room for growth. As you can see, at least an additional 20% of all Medicare, Medicaid, and commercial office visits could be transformed into virtual medicine. Now let's turn our attention on the why you should care about telehealth. First, healthcare is unaffordable. According to the Bureau of Labor and Statistics, the average income for Americans was close to $4,000 a month, or $47,000 in the year 2019. There is considerable variation amongst people depending on their level of education. Additionally, 1/2 of all Americans have a high deductible health plan. 3 out of 5 Wisconsinites have a high deductible health plan. The average premiums for most people with a high deductible health plan is around $5,000 per year. This is around 10% of their annual salary. This does not count out-of-pocket expenses. A high deductible health plan is defined by the IRS in 2021 as a plan with a deductible of $1,400 for individuals and more than $2,800 for families. The out-of-pocket expenses are up to $7,000 per person or $14,000 per family. In the worst case scenario, this could wipe nearly half of the pre-tax income of a person with a family. This results in half of Americans spending more than 10% of their income on healthcare. The lower the income level, the higher the cost burden. To worsen the situation, Americans are broke. 4 in 10 Americans are unable to afford $1,000 as an emergency. On top of that, Americans are saddled with medical debt. As you can see, 1 in 5 Americans have medical debt. And this debt adds up to eye-watering amounts of money. This led to 1 in 3 Americans not to seek medical attention because of the cost. Also, 1/4 of Americans were unable to afford their prescription medications. Additionally, there is very significant variance in the cost for the same type of medical procedure and lack of transparency in the cost of consumer healthcare services. As you can see in this example offered by the Kaiser Family Foundation, the changes or difference in price for an MRI it varies incredibly from place to place and even within the same city. At a national level, the US has spent $3.8 trillion with a T in healthcare. This has led the government to propose a price transparency for healthcare plans in a bipartisan manner in 2020. Medicare already has price transparency tools for several services and providers, which you can find in this page. Some private health insurance companies have price comparison tools, and they've had them for several years, like this example displayed here for Blue Cross Blue Shield. Some price transparency companies are working with large employers, so you might have access to these tools through your own employer. And other price transparency tools are available to the public. This is an example of a diagnostic polysomnogram in Milwaukee. And you can see the difference here between the average of $3,020 with $1,500 that they're offering you here. Here's another example of a home sleep apnea test in the Milwaukee area, and showing that another big difference. I would also invite you to call your own hospital, your own place, so you can see what is the cost difference between what your institution is charging versus what is the national average. I was able to see that some places where they're charging as much as $5,900. Remember now that 40% of Americans struggle to afford $1,000. Turning the page into demographics. One-third of the Wisconsin population is rural, which is close to 2 million people. Compared to their urban counterparts, rural America has higher mortality and worse healthcare outcomes. Why, you might ask? First of all, geographic distances to healthcare facilities. Primary care providers and specialists is much greater in rural areas. This in turn decreases access. As an example, I have patients who must take half a day, if not a full day off work to see me. Why? They have to commute 90 minutes each way, on top of finding parking, walking into the clinic, checking in, the time of the appointment itself, and then they are forced to use their paid time off if they're employed full time. This makes it extremely inconvenient and difficult for people to seek medical attention. Additionally, almost 1 in 5 seniors don't have internet access at home. One in 5 Americans living in poverty do not have access to the internet at home. And in rural America, the lack of internet access is twice as much, affecting almost 1 in 7 people. Poor seniors are the ones that are most affected, making up to 2/3 of those without the internet. This map was obtained from the Federal Communications Commission, or FCC, and I encourage you to explore it. You can see here that better broadband access leads to better healthcare outcomes. Therefore, some experts consider access to broadband internet another social determinant of health. Now, you must also be aware that your competition is changing. These are your traditional competitors, neighboring healthcare systems. Maybe a small independent hospital lucky enough to have a sleep specialist. Even more rare is the independent freestanding sleep center. These centers took a beating in 2020 during the height of the COVID-19 pandemic. You may also have sleep care management companies that have been using telemedicine and traveling technical staff for many years to help small rural hospitals with turnkey solutions that help the local population. There are now large national telemedicine companies employing sleep physicians to provide sleep medicine services at a low cost. Services are not limited to sleep disordered breathing. They are also helping staff some healthcare systems and provide services that go beyond sleep apnea. Another option for people is to meet with a sleep physician providing direct care. This is fee for service without health insurance. Diagnostic, testing, DME are all done using telemedicine. All the prices and services are posted in their website. This company was founded in 2014, before telemedicine was considered popular. The cost of care is much lower because there is a significant cost savings that is passed to the patient when bypassing health insurance, credentialing institutions, and large commercial real estate. Many non-sleep specialists offer treatment and diagnoses for sleep disorders, especially sleep disordered breathing. They usually don't employ sleep technologists. So how do they do this? With the help of national testing companies. These national testing companies have allied themselves with other large national durable medical equipment companies, or DMEs, until the recent past. You can still find co-branded forms with the names of a testing company and a DME under the same form if you Google this. I'm not going to mention any names here, but you can Google that. Now, the forms are easy to complete for your office staff and the practicing provider. Note that this form has 7 different types of home sleep apnea testing. How can this be? So this company uses different types of home sleep apnea tests. For the first one on the left, they offer a sleep profiler PSG2, a subtype 2 unattended home sleep apnea test with EEG, EMG, and EOG over 2 nights. The others are type 3 home sleep apnea tests. They offer home sleep apnea testing in children and with PAP. These 2 latter options are not recommended by the American Academy of Sleep Medicine, but people would know better unless they're sleep specialists. This is very important that you're aware of the type of studies and tests that are occurring outside of your lab, because these are offered as low-cost alternatives to patients who are looking for something to treat their sleep disorder breathing at a lower cost. Now, Virtuox, which is a testing company, they also work in partnership with its sibling company, Dog via Web, which provides sleep medicine and telemedicine interpretation for their home sleep apnea tests. HMR WatchPat is another company that also markets to cardiology and dentistry. Some companies market directly to the consumer. This company was started by an engineer in the Bay Area who was disgusted by the overall negative experience of being diagnosed with sleep apnea in a regular clinic. He thought about a user-friendly, high-quality, and cost-effective solution to help most people with obstructive sleep apnea. Notice how, with a very reasonable price, you can get tested after positive self-screen. In addition to therapy, and support, everything for under $1,400. They even have monthly payments of under $90. This is less than half the cost of a diagnostic polysonogram in Milwaukee. You can do All this from your phone or PC. If you already have obstructive sleep apnea and need a prescription to renew your supplies, no problem. Only $35. They even advertise to patients through the ASM under the sleep education website. Other companies are doing similar things. Now, also think about big box retail, Walmart. I have seen their presentation on Walmart Health during the National Telemedicine Conference. And they say that most Americans live within few minutes driving to Walmart. And they are able to provide cost-effective direct care without insurance. They have deep pockets and a supply chain process that will beat any healthcare system, allowing for a very competitive pricing. Walmart Health locations has already increased and improved their operations in Georgia, Florida, Arkansas, Illinois, and Texas. Walmart has plans to install 4,000 primary care supercenters in stores by 2029, which will include clinical lab and testing services. Amazon, look what they did to the malls. They already are strong in pharmacy and medical supplies. Fitbit is seeking FDA approval. Apple has published an abstract, and Garmin has been reporting oxygen data for a while. I had 3 patients with obstructive sleep apnea who came to me alarmed because their wearable devices had told them that they had low oxygen levels and that they should be tested. Implementing or improving telehealth in your institution can be very helpful and will serve your patients better, and you will be more competitive. To do this, you must remember the following. That healthcare is expensive, often unaffordable for most people. This is why most Americans have trouble paying for their healthcare needs. Large portions of Wisconsin are rural. Distances and poor internet connection affect healthcare outcomes. The poor and the elderly are the most affected. Telehealth can help bridge this gap. So, how do we do this? First of all, we can't be complacent. We must do better. Inform yourself. The AASM has an excellent website with information about telemedicine that's comprehensive and relevant to sleep specialists. Additionally, be aware that your technical knowledge as a healthcare worker is invaluable. This is a good example of respiratory therapists improving adherence to PAP therapy in a pediatric sleep apnea clinic, and there are many other examples like this. Additionally, you should lean on the expertise of various team members in a coordinated and systematic manner to up your game and take better care of patients. We should also improve broadband internet connectivity in rural America. This is a social determinant of health. And as you can see in these maps, the amount of people who don't have access to quality internet is really very significant. Here is an example of creative thinking and multi-institutional collaboration, leading to solutions outside of the box. Here you can see a pilot project to provide high-speed internet to 50 rural homes and businesses in the Eau Claire region with a collaboration of the Wisconsin Economic Development Association with Marshfield Clinic, Mayo Clinic, Hospital Sisters Health System, Chippewa Fall Valley Technical College, and PSI with the Starlink program so that people can have better connectivity, and this could help improve businesses and education. We should leverage technology for the benefit of patient care and diminish clerical work that burdens most healthcare workers, not the other way around. Here are some examples of apps that are used to help improve adherence in PAP. They're intended for patient use, but their implementation has been shown to help improve adherence. There are also many other apps used to treat insomnia by providing internet-based CBTI. These tend to work better for those who are motivated. And you must carefully examine each individual and their needs and understand the capacity of these apps before recommending them to any particular patient. Be familiar with the telemedicine billable services. Medicare has created several new codes last year. This information will allow you to accurately document and receive payment for your services. Now, let me give you some practical examples of what we did at the Gunderson Health System in La Crosse, Wisconsin. Here are some examples of things we've done at Gunderson. Number one, the ability for patients to self-schedule with their provider of choice or the slot that might be available to them. Secondly, their ability to e-check-in. So they can check in through their phone or a laptop computer before their appointment to announce that they're getting in and have everything completed. This e-check-in includes sleep questionnaires that are also available in the portal. These sleep questionnaires are for new patients that are adult and a separate one for new pediatric patients. You also have the FOSC Q10 and the Epworth for all patients, including follow-ups. These questionnaires help feed the flow sheets in our EMR system, which in turn can come up with smart phrases in their documentation. We also provide telemedicine services to other clinics. They can be clinic-based, such as what we do with Mountain View in Adams Friendship or with Platteville or West Union. But they can also be home-based, where the patient from the comfort of their home or any private environment, as long as they are within the tri-state area of Wisconsin, Minnesota, and Iowa, can be seen by one of our providers. The main limitation of this is when people don't have adequate broadband internet connectivity, and sometimes things can be very spotty. Another obstacle there can be some patients who might prefer to see someone in person. And then finally, we have the option of doing things by phone when there's a strong need. Reimbursement is much lower over the phone, so it's not something we recommend for everyone. We've also come with creative ways of helping people who have well-controlled, uncomplicated obstructive sleep apnea by renewing CPAP supplies through an e-visit. The e-visit is an asynchronous form of communication where the patient can enter their access through my chart, and they complete an Epworth, a FOSC. They then report they're using their machine regularly, and they were going to also answer if they feel better clinically with the machine once this occurs. The information is sent to one of the respiratory therapists who obtains a download of their CPAP machine, and then if everything looks good in regards to adherence and effectiveness of treatment, this is forwarded to one of the physicians to review, and if everything looks good, the prescription is approved, and the patient is given a copy of the prescription, which is printable through their My Chart, as well as a small note. This is done from the convenience of their home, and is available 7 days a week and 24/7 for a patient who wants to do this. It's much more convenient and cost-effective, and again, for people who have well-controlled, uncomplicated obstructive sleep apnea. This was a solution brought about to people who are doing very well with their machine. They come every single year, always doing happy, 100%, 98% use of their machine over than 4 hours, always doing great, yet they have to take off from work, as we mentioned previously, just so they can have a very short visit. So this way, they can provide our patients more value for their time, but at the same time, we're always available to see them if they need some additional care. If the download showed either poor adherence or a high residual AHI, then that appointment is reversed, and the patient is instead seen in clinic, either in person or via a virtual visit. We've also greatly expanded our home sleep apnea testing program, offering various types of testing, including type 3 and PAT devices. We are not using the Wi-Fi enabled disposable devices because there are many areas in rural Wisconsin that don't have that good connectivity, and therefore we would have a high rate of failures if we did that. Also, we rely on our daytime sleep technologists who've obtained their CCSH to call most patients with their sleep study test results. And this way they can convey the results and recommendations provided by the physicians, and allowing the patient to get started on treatment quicker and at a lower cost. Also, we rely on our respiratory therapists who help us prep charting, obtain downloads beforehand, pen PAP prescriptions, work with our compliance program, doing mask fitting, although some of this has changed since COVID-19. Hopefully we'll get back to that very soon. And doing a lot more, and relying as a team, we've been able to have great outcomes for patients and help lower the cost and improve access to those who need to see us at a sooner time. Also, we've partnered with several rural hospitals across Minnesota, Iowa, and Minnesota, and we've done several things for them so we can support their sleep program, either by providing virtual visits or telemedicine services to their clinics, helping them with home sleep apnea testing, or in some cases, working with the accreditation of their sleep centers and training either a NP or a PA so they can have their own program, which is thriving. This has been a very rewarding experience, as it's helped provide people living in remote rural areas with quality sleep care close to home, while supporting their local hospitals and improving this partnership that Gunderson, my institution, has had with other smaller rural hospitals. Finally, we should discuss the fact that the prices must drop while quality should keep improving. And to do this, we must rely on team care, technology, price transparency, and we should also emulate some of the best practices from our competition. Remember, we have to do what's best for our patients if we want them to thrive and our institutions to survive. We can't continue with these differences. Remember that one of the online services we presented before was offering a home sleep apnea test for $189, where some hospitals are charging almost $6,000 for a sleep study. This cannot continue. Here are two different pathways that you could follow if you're a sleep specialist and want to do more depending on your work situation. First of all, if you work for a healthcare system, make sure you leverage the resources of your employer. Also remember that changes are slow. Therefore, be patient but persistent. Also make sure that you recruit the help of other team members. Make sure you discuss things frequently and closely. That way they can provide you with their ideas and they will have a buy-in into the whole project. Make sure you check your competition. See what things are doing better than you are. What things could be emulated to better take care of your patients. Make sure you involve administration early on, okay, so they oftentimes will hold the strings to the economy and the purse that you will need to start your project. Make sure you have legal and compliance on board to make sure that everything is done correctly and properly, and to recruit information technology IS team so that they can help with your project. They're going to be your best friends. Marketing, of course, we shouldn't forget. Now, what if you work as an independent healthcare provider? You can start a virtual sleep telemedicine practice for a very low cost. I would say even under $5,000 for a full year. It all starts with you having your own employer identification number, which should be attached to either an LLC or an S Corp or many other ways. You should also have a cloud-based EMR, which can be obtained at a very low cost, sometimes under $100 per month. There's some EMR systems that are free, but their cost is, but they're a little bit more difficult to use. You also have very low cost and free HIPAA compliant videos that must have a business associate agreement. There's various examples of them, and many of them, as mentioned, tend to be free and offer the capability of getting started there with your programs. And finally, don't forget a payment processor company, such as PayPal or others, that would allow you to charge for your fees. Some EMR systems can provide you with a comprehensive system that'll give you the EMR, the video that's fully integrated, and the payment processor all in one. I know that the American Academy of Sleep Medicine offers like one of those solutions, but they're not the only ones. So there's many other solutions at companies that you can look into so you can get started on something independently. Now, we must never forget making sure that you have malpractice insurance and that you're compliant with all the needs of the state in regards to licensing and educational credits. So this way, I said, you can get started from very, very little, pretty much from your home office or a small place, and get started with a virtual sleep clinic. To summarize, digital solutions offer new tools and more flexibility to improve patient care by increasing value, which is better care, higher quality, lower cost. Be aware of the obstacles because they're growing and changing. Your competition is also becoming more fierce. So this, I thank you all for your attention and leave this presentation open to questions. Thank you very much. Okay, well, thank you everyone here for the for your attention, and I'll leave things as it open to questions. Let's see, I'll scroll back and see. I think I did see here's some comments. So first of all, there were some talks about the audio, and I must admit, yes, the first we did start a little bit late, and there were some technical issues, especially with the audio, and that affected that first talk in this room. So that's right, but you should all have access to a copy of all the talks, including the first one and every single one, through the Wisconsin Sleep Society in the next few days. And let's see here. Here, there was another question here about the ability to provide test results and by someone who's not licensed. So first of all, anyone who works with us is licensed, but it's just the concept of team-based management. So, many years ago, a physician could do everything on their own. There was no need for much. It was, as I said, just between the patient and the physician. And then as things became more complex, they became many more conditions, more technology, more medications. So there was a greater need for more knowledge and more specialties. As the advent came there with Second World War and freeze of salaries, there also came the advent of health insurance, which was tied to the workplace, and other benefits. With health insurance came again more control of pricing and then documentation, and then that added to an escalation of additional staff to do several things, especially with coding, billing, and with more regulation that created again something that's made the cost of healthcare grow significantly. So regardless of where you stand politically, I think everyone can agree that healthcare is quite expensive the way it is right now, and a lot of people are having a hard time affording that. But the concept of team-based management has to do with again, it's a physician who works as in partnership with again other physicians. Could be advanced practice clinicians like PAs or NPs, nurses. We can also work with medical assistants, sleep technologists, respiratory therapists, and then as a team work on the management of different things. You might also incorporate like dentists or psychologists, depending on the size and type of team that you have. And this way you can manage things appropriately. Everyone is licensed, as I said, on their specialty or their profession, but it is making sure that you can work in a way that's coordinated and efficiently. This can allow you to care for more people and also have better documentation of the things that are required by insurance. So in our case, when we write the orders, again, we write down, as I said, the interpretation and the orders for let's say there's a person at a sleep study, and they'll say that they have sleep apnea, they need APAP, we'll write the specific orders. So the sleep technologist who has gone through their advanced training through the CCSH is going to call the person and just convey the plan that was written by the physician. So they're just communicating that plan and not providing any independent assessment or plan, but it does help a lot as those patients are grateful to get their test results sooner. It saves them an appointment, and at the same time, it opens our clinic to see more patients, some of them who might be new, who might need sleep studies. So it's a win-win for everyone. And here I see someone in a sleep tech from Margin RT. There's a sleep tech RT with a master's in public health, and at one time proposed a case of managing pulmonary and sleep patients to my facility case management department. I was shut down despite having the same education as the nurse care managers. I did not have my RN. Unfortunately, is that there's been a lot of internal politics amongst different professions and their lobby groups. So that's a conversation that's probably bigger than all of us. Unfortunately, RT, sleep techs, physicians, PAs, that there's a lot of lobbying that goes on the side, and sometimes looking at ways to create a moat around their professions. Think is that if we want to truly improve things, we must make sure that we work better together, because otherwise the non-healthcare workers, like you've seen, people from Walmart, people from Amazon, people in the technology department are going to eat our lunch. So we have to be careful about that and think who is it best to partner with. Then let's see here. Next time, talk about the future. Well, a lot of this is also the present. Sadly, I said things are moving fast. If you really want to open your eyes, one thing I've seen just 2 years ago was that American Telemedicine Association meeting. They usually hold their meeting in spring, and it was incredibly eye-opening just to see all the changes, all the things that are happening. And the one thing that I found most surprising is that there are very few healthcare professionals that are involved there, and it's a lot of business people. There's a lot of technology aspects that are involved there. So again, why? Because again, there's where the money is, and they're looking a way in which they can, have a small piece of that, $3 trillion pie. Then let's see here. There's another one. This is from Ryan Braden. Does telehealth alleviate the requirements for the physician to be in the facility for billable services performed by CCSH? So if I'm not mistaken, so there's again a couple of questions there. First of all, the CCSH, and this is an advanced degree given to sleep technologists who've gone through additional training to consider themselves. The biggest obstacle that they currently face is just finding that ability to be recognized as a specialty by the federal government. And this way they would be able to provide billable services like a respiratory therapist or a nurse could. So for those who can, my understanding is they need the physician to be in the same place physically, not just via telemedicine. So with that, as if you have direct supervision, if someone is there in the same place physically, or indirect if they're available on call. So my understanding is that person has to be in the same facility physically. Let's see here. I think already aware of the expenses and change in technologies to patient ratio in the near future. Let's say elimination of 1 to 3 or 1 to 2. Well, I'll tell you what. I don't think that tech to patient ratio is going to change 1 to 2. Probably you might have more like one-on-ones. And the reason is most of the people, those who are practicing this for over 10 years or maybe 20 years, you can remember that most of the people you studied were very easy. Just a middle-aged individual who was slightly overweight, maybe hypertensive. They snored. You did a sleep study, maybe a split night, easy goings, easy pickings, and there they went. Now, most of those will have a home test. And Those who come to the lab are usually elderly, they're frail, they have falling problems, they might have behavioral issues, you might have children. So you can't do a 1 to 3 on those types of patients. You might need to do more, sit like a one-on-one even, or sometimes even like a 2 to 3. So it can get trickier. The patients we're getting are much trickier, that they are much more difficult. So for those who are in the sleep technology business, it's very, very hard to work with patients who need sleep studies now, because they're much sicker. So I don't think you'll be doing 1 to 3 anytime soon. And they're telling you that you have to do that. You guys are in demand. I'm pretty sure you'll be able to find a job pretty quickly. And let's see here. I think there was some comment about the illusion or the delusion about trying to do more with less. I know that's sort of like a spiel. And again, it's not about doing more with less, because that goes up to a point. But beyond that, you'll compromise on quality, or your people are going to burn out, like we saw in that excellent second talk, Dr. Millell and Tobert. So burning out or people quitting is not the answer, because I said either quality compromises, people go out. But I think it's important to, one, think out of the box, see what things are coming, and not be ashamed to look around and see what good things all the competition is doing, and maybe emulate some best practices. Two, make sure that you trust on your team. Yeah, like I said, one person can't do it all. Otherwise, I said you want to have the capacity to absorb the volumes or manage all that. And there's a lot of technology that we can use intelligently. So if the technology makes you work more, like some of these medical records or documentation is taking, I forgot that there was some study that showed that the average doctor spent an additional hour and a half each day documenting. Well, that's just nonsense. So you have to find the solutions that are easier for you, that'll actually help you, not make your job more onerous. So we have to leverage the right type of technology so that you can do what you want to do, which is take care of patients, and less of what you don't want to do, which is just some ancillary things that don't bring you much joy. And if you can find that team or that group of people that can help you achieve your goals, and I think that will ultimately lead to improved patient care, thinking out of the box, and working with enthusiasm to help people. But we just can't do everything the same, because that's just not sustainable. Let's see here. So we talked about the medical billing. Are you aware of the expenses that you anticipate any of the sleep technologists? Yeah, once again, I said that those expenses, they are there, and sleep technologists are in high demand, especially, I said, in rural areas. It's very hard to hire a sleep tech, and I said what you do is very specialized, it's very niche, and yeah, you won't have any trouble finding exactly to bill. You need an NPI. So that's bingo. Who said that? Angela Childs. Thank you. You got it. So if you can't get an NPI, you can't bill for services. That's a tricky thing. So how do you convince the hospital administrators that keeping the patient ratio low affects quality? Well, that can be, I said, quite tricky, but in some cases you have to think like the administrators. You have to say, what are they looking for? And looking at the business case, but sometimes you also have to look at patient safety. So patient safety always trumps the business case of medicine. So if there is a sentinel event for issues like that, that's something that can always be utilized. But by then, no one wants a patient getting hurt, like in your lab or under your care. So those are the types of things that you want to prevent. So we would be, I said, very happy, I said, to share, I said, some of the reasons that why we do like following for like a full safety survey for all patients before they have their test, and depending on that, we also determine the type of care that they need. Because again, our patients are much trickier, you know, and at the end, again, remember that as a sleep tech and as a healthcare worker, there's a lot of people who are retiring, who are leaving, and you actually have leverage. Because I said, with your profession, you're in demand. As I always believe, it's a one-on-one is more efficient. The one-on-one is efficient for certain cases, absolutely, but it's some of the more simple patients that they can be done as a 2-to-1. I think that that's been the standard set by the ASM, but there's definitely several cases that need to be a one-on-one. As we said, some people with behavioral problems, you know, younger kids, those with neurodevelopmental problems, they might need to be one-on-one. So hospitals and private facilities do it every night, correct? I mean, that's right, but at the end also we have to see, is it what type of, remember again, you have the power, is it to pick your place. And at the end you have to do what's right, what feels safe for you. And I know that there's a lot more that goes into it. Like if you have a house or a family that's embedded in the community, sometimes